Hello and welcome to this presentation about the medical imaging department. There are a lot of different things going on within this department and a lot of different professionals that you'll be encountering. This video is presented with the perspective of patients and what you might encounter during your stay at a hospital or outpatient clinic and what we can do for you. All right, so here we have different modalities or different types of machines that we use within the medical imaging professions. The Radiologic Technologist or X-ray tech is the oldest of the profession. Radiation therapy, nuclear medicine, sonography, cardiac electrophysiology, cardiovascular interventional radiology, cardiac interventional, CT, MRI, mammo, bone density. Registered radiologist assistant is one of the newest ones of the profession. Echocardiography, management, education, PACS administration, and mixing and matching what you want to do within the profession. So some of the people that you will be interacting with will be able to use different machines on this list or different modalities and be able to produce either a diagnostic or interventional result at the end of the exam. And lastly, but not least, the limited technician, which is different from the technologist that we talked about just a minute ago. And we'll go through each one of these. The organizations behind the credentials, there are quite a few, as you can see here. The ARRT is one of the oldest ones because that was the first profession in medical imaging was X-ray. So in the ARRT, the American Registry of Radiologic Technologists, there are a lot of different things that you can do. So each one of these initials is a different modality that you can be credentialed in and perform those exams. The ARDMS is for the American Registry of Diagnostic Medical Sonographers, okay? And you can be different areas of specialty within that organization. The ARMRIT is the American Registry of Magnetic Resonance Imaging Technologists. So you can see that this deals with MRI, but the ARRT also has an MR or MRI credential as well. So there's two pathways to get there. It just depends on which organization you did your exam through and passed. The CCI deals so the CCI and the ABHRE both deal with cardiac arrhythmias and cardiac devices. So the CCI is dealing with one of those and the other is for devices. All right, and we'll go through that in a minute. You can also get credentialed through the Nuclear Medicine Technology Certification Board, and you can get the initials CNMT. All right. So most people will take this credentialing exam, as well as the ARRT. You can see over here, there's an N that stands for nuclear medicine. So they'll both be the CNMT and the ARRT M. So it just depends on what pathway they chose, and sometimes they'll choose both of them. So let's start with radiology. So there are several names that the X-ray tech goes by. So X-ray tech, X-ray technologist, radiologic technologist or rad tech, or radiographer. All of those are appropriate and are synonymous. Okay. So when most people think of X-ray, they think of X-raying of bones, all of the entirety of the skeletal system. However, we can do a lot more than just X-rays of bones. We also can take a look, as an example here, look at the intestinal tract. And we can also look at the urinary system, as well as pretty much any other system that you can think of. Now, where do we find X-ray techs? They're in the hospitals, in the ER, the OR, the nursing units. So basically anywhere you find a patient in the hospital, you'll most likely be able to see an X-ray tech somewhere in that department as well, taking an image. There are some exceptions, of course, but we go all over the place. And we have our own imaging department with our large X-ray machines that fill up the whole room. Those are really good for a lot of procedures. And we can also go up to the nursing unit with a portable X-ray. So those portable X-rays you see going around are $60,000 to $100,000 worth of machine. So it's a very expensive thing going around, and hopefully not banging into walls and things like that. Hopefully the X-ray techs have their X-ray tech driver's license. All right, where do they work? The majority of X-ray techs work in the hospital setting, but you will find us in outpatient clinics. You'll have travel techs. So if there is an area of the country that has very limited quantity of X-ray techs living there, the hospital might have a travel tech come and work there for 13 weeks or so. Usually that's the contract time. And they get acclimatized to the hospital, and they take the images so that the X-ray department is fully staffed. We can also go and use that same portable unit that we go to the nursing units with. We can put that in a van and go to skilled nursing facilities and take images there. That saves the patient from trying to go from the nursing unit, take a medical transport or ambulance, move them to the hospital, take the 2-minute X-ray for it. Let's say it's a chest X-ray. It usually takes 2 to 3 minutes to do that, and then go back via medical transport or ambulance and back to the nursing home. So we come to the person and take the X-ray where they're at. Of course, there are some limitations with that, but chest X-rays and abdomen X-rays are, in any of the skeletal ones, are fairly easy. There's some technical factors for the skeletal X-rays that make it a little more challenging to do, but it is most of the time possible. Radiation therapy is another arm of the medical imaging profession. These professionals will be ARRT. T is for therapy, and some will come in being an X-ray tech first. So you would have an ARRT, R for radiology, and then T after that. They work closely with oncologists to make sure that they are planning the doses of radiation to go to the right spot and have the right energy level. They also work with the dosimetrist. The dosimetrist is a subset of the radiation therapy world, and they are able to calculate the energy that's going to be deposited into the body, and make sure that they are aiming it and shaping the beam to the right spot, so it kills the cancer cells and leaves the other cells around them to have a better chance of surviving and recovering. So you have those things that you need to worry about. Is it shaped correctly, and is it the right energy level for what body part we are trying to interact with? Because of this, these are not portable. You find them in hospital imaging or cancer centers. So the patient always has to go to them. The walls have a lot of, they're very thick and specially constructed so that any radiation that's in the room doesn't leave the room and expose people outside of the room to any radiation. Okay, so you can use particle beams or radiation to do the imaging and cancer treatment. Okay. Nuclear medicine is another subspecialty. You can be an X-ray tech and then transfer into nuke med. You can get into nuclear medicine without being an X-ray tech first. And you have a couple of pathways for credentialing to get there. So you will be doing in the nuclear medicine technologist, will be doing diagnostic studies and seeing both the anatomy and physiology of the body part. For example, this is a cardiac scan here, and they're taking a look at the muscles to see how well they are interacting with those tagged radioisotopes. So a radioisotope is an element that gives off energy in one fashion or another. So we use different types of radionuclides to get the pictures. So we have gamma cameras, and we have cameras that will pick up the radiation and see what type of signal is achieved, right? So here's a cardiac study. This is a study of the bones. You can see the highlighted areas here. So there's a lot of useful information that you can get. You also can have what's called a PET scanner. So that's the positron emission tomography. So that's PET. And then some of them will be PET plus a CT scan. So you have a CT scanner, which provides high resolution imaging for structure of the body. And you have at the same time, you're getting PET. So you have the positron emission being calculated, and that gives you the physiology of that area. So you can get both the structure and physiology at the same time. So that's a really nice exam if that is warranted for whatever we're looking for. Now you'll notice that we have a lot of different modalities within them, all right, within the imaging department itself. Each one has its own strengths and weaknesses. So that's why we will do one exam over a different one. It's because we're different. We're looking for different pathology. We're looking for different information. So because of the physics behind the image creation, some exams are better with one modality and they're still okay with a different one, but not as good. So we always have to weigh which imaging type is the best for what pathology or disease state that we're taking a look at, right? So it just depends. You can take a look at the heart in like 3 or 4 different ways. So it just depends on what information you need about the heart, and that drives where you want to go, what your physician will order for you. You'll find nuclear medicine techs in hospitals, imaging departments, and clinics, okay, outpatient clinics. Again, these machines are not portable. You have to come to the exam room itself. Sonography. All right, so sonography is using sound waves in the ultrasound frequency range. So we have audible sound, and then we have sound waves that we have a shorter frequency, and those are ultrasound. So the ultrasound sound wave is produced in a crystal, and it is in a device called a transducer. And that transducer has crystals in a certain format. The sound wave is emitted from that transducer, goes through the gel that's on the transducer top, and through the skin and into the body. And then the interaction of that sound wave with whatever it's traveling through, the sound waves bounce back, and it's calculated on how far or how long that was, and an image is produced. Okay, so a lot of people think of only fetal imaging, right? So that is a very common exam, but it's not the only exam we do. So the professional in this one could be an X-ray tech first and then transferred into ultrasound, or they can be a direct ultrasound without X-ray background. And the schooling varies in length, but they will get some education on how to look at these images. For example, this is a color Doppler image. So you can tell by the sound waves if these sound waves are bouncing back at you at a different rate. You can see if the vessel is moving to you or against you. So you can see if it's a vein or an artery, depending on the color coding of the image. Okay, so there's multiple things you can do within the ultrasound profession. So there are our DMS, so that's the Diagnostic Medical Sonographer, and they can do any body part. So they can get credentialed in OBGYN, so that's the fetal component. They can be a vascular tech, so they're taking a look at the images from the vascular system within the body. There are a couple other ones. You can be an echo tech, which we'll talk about later, and that's looking at the heart. You can be a muscular skeletal ultrasonographer, so you're looking at the joints. And a lot of the people in the profession will do multiple areas so that they can do anything that comes through the door. All right, so you'll be able to see these people, these professionals in hospitals. They go to the ER, the OR. Of course, we have an imaging department, so they have their units in their own special room. And they can go portable to any of the nursing units. So you'll see these people performing their work in a variety of settings. And of course, you can be an outpatient clinic as well. Cardiac electrophysiology specialist. All right, so these people can be an X-ray tech that's transferred over and learned cardiac EP, electrophysiology, or they can be a professional that focuses solely on EP. So you have a variety of backgrounds that come through. You can be an EMT and learn how to do this. You can be a nurse, you can be an X-ray tech, or you can go straight in from doing your prereqs right into the program. I am the program director of this one. So there are three main things that you do within the cardiac EP realm to start off with. So one is the detection and treatment of cardiac arrhythmias. So what we'll do is we will put in a special catheter. We'll take a map of the heart. We'll take a look at the timing and see where the abnormal conduction is. So we are the electricians of the medical world, and we take a look to see if there is a bad wire, basically, has your heart short-circuited. If it has, we take the images to find out where, right? So we do the 3D mapping to see where exactly that bad cell is located. And then we can do what's called a ablation. So we either take radio waves and heat a catheter with a metal tip, and that metal tip is touching the cells that are misbehaving, and we knock out those ability for those cells to conduct any electricity. Once those cells are non-conductive anymore, they can't either trigger a heartbeat at the wrong time or propagate it or spread it, right? So once that is gone, the normal pathway should take over. Okay, so that's the first two roles. The third role of the electrophysiology specialist is to help with the implantation of pacemakers or cardiac devices or defibrillators. So the ICD is the intracardiac defibrillator. So you are going to be the person in that team will be the EP specialist is going to stand next to the electrocardiologist or cardiologist and assist with that. So in this field, you'll have a team setting. So there'll be a nurse, there might be an anesthesiologist, physician, there'll be a cardiologist, which is had special training. So that's electrophysiologist. You'll have the EP tech or X-ray tech, EP tech. And in some states, you'll have an extra X-ray tech to handle the X-ray machinery. All right, so that's the main profession. After 2 years of experience, the person that was assisting with implantation can be a pacemaker rep. So they have pacemakers or ICDs in their car, and they'll drive to wherever your operation is going to be and assist with that. They'll bring the pacemaker and the pacemaker leads, whatever is appropriate for your specific pathology or the error that's happening in your heart, right? So the physician will call the pacemaker rep, and they will say, I need this type of pacemaker with these leads, and I'll see you at 2 o'clock. So then they show up and participate with that implantation and program it. Okay, so the programmer and the physician work together to say, okay, I want a beat of 60 beats per minute, and I want it to sense in the ventricle. So there's a whole bunch of things that they need to know to make sure that they're programming that device appropriately. And that professional is the CEPS. All right, so hospitals, heart clinics. So the majority of people in this profession will work at hospitals, but you can see them in a cardiologist's office as well. Cardiovascular interventional. So most people just call this interventional radiology, or IR. You are working in a X-ray suite. Here is a Cath Lab. Excuse me. Well, you can have a Cath Lab IR suite combo, but this one specifically is an IR suite. So you have a C arm, and it gets that name because the device looks like a C and has an X-ray tube and capture device, imaging capture device on the other side. So that's called a C arm. And these will be X-ray techs, and they will be able to help with interventional procedures. So if a person needs a tube put in at some place, they can put a tube in to help relieve pressure or do drainages or biopsies. There is a lot of things that this specialty can do. And this focuses on every body part except for the heart. All right, so all the vascular system, etc. Okay, solid organs. They can do biopsies, drainages, as I said before. They can implant also other devices. This is what is called a IVC filter. So the inferior vena cava is the large vessel that is a vein that transports the blood from the lower extremities back up to the heart. So that's the inferior vena cava. There's a superior vena cava as well, the SVC, and that is carrying blood back to the heart, but it sits above the heart, so that's superior. All right, so here is a tube that they're putting in. Okay. So hospitals and surgical clinics will have these professionals in them. Cardiac interventional. So this is the counterpart for the cardiovascular interventional. This specialty looks at just the heart. There's a lot of specifics that go into working in the lab. So you want to make sure that you have someone that knows what they're doing. There's 2 pathways to get there. This is a team work environment. So you'll have an X-ray tech or a cardiovascular tech. You'll have nurses, anesthesiology, a physician. So you'll have all those people within the lab. So for the X-ray, the imaging part, you can either be a ARRT, then get additional training and pass another test. So CI, so that's the cardio interventional. So you'll see these people with ARRT and then CI for their credentials. You can also be a cardiac So the RCIS, so that's Registered Cardiac Interventional Specialist, and those are credentialed through CCI. So they can do everything except for move the X-ray tube. And it really depends on what state you're in. Each state will have slightly different rules. There are some national standards, but there's the national standard, and then the states can add on to that standard as well. So it just depends on where you're at, what specifics. For example, in California, where I'm located, the RCIS cannot move the X-ray tube. It has to be a radiographer. There's a couple other states that have the same. Doesn't mean that this person can't work in California. It just means that they have to have an X-ray tech in the room or have the physician move the X-ray tube. All right, so they focus on the blood vessels, and they can take a look and do interventional procedures on valves. So they're quite versatile. These are the plumbers. Okay, they're the plumbers of the heart. So we had the electricians, the EP people, and we have now the plumbers as well. And of course, we call the orthopedists the carpenters, right? They're in there using different machines and saws and etc. All right. You'll find these in the hospital or surgical hospitals with if you have a backup for cardiothoracic surgery. So it just depends. And a Cath Lab suite is an OR suite with just special equipment in there. So you'll get the sterile protocol, etc. And here's a team of people working. They have an ultrasound machine to help them get the vascular access that they need. You might get a tube in your wrist, so that's the radial artery, or in your groin, which is the femoral artery. Just depends on the specifics of the case and also the physician's preference. Okay, CT, computed tomography. This used to be called CAT scan, so it's CAT. We dropped the A because that stood for axial. So it used to be computed axial tomography. We dropped the A because we can do sagittal and coronal slices or cross section as well. So in this profession, the professional needs to understand the cross section. So it's like taking a loaf of bread and cutting it into slices, and then you take a slice out of the middle and you can see what's on that slice. So for example, if it is a raisin bread, you cut that in, and when you pull it out, you can see all the raisins neatly arranged or arranged on that slice. Whereas if you took an X-ray of that loaf, all the raisins, no matter where they were, if it went through the whole loaf, you'd see all of the raisins, then they'd be all superimposed on top of each other. So this helps separate individual slices or parts of the anatomy out so that the physician can see it. For example, here is the liver, and this is the aorta. So we can tell right away that this aorta has this little flap in here. So we can tell that that's a pathology or a error in the anatomy. So this is a flap of the inside of the aorta that's been ripped off, and now you have blood flowing and tearing that layer off from the inside. So it creates pain that moves through the body as the aorta is ripped. So it is can be a dangerous situation, and it's important to know what's happening. This is a scout for a head CT, and the CT slice is going to go through here. So when they actually take the image, you'll be able to see all the bones and soft tissues in that slice. Okay. All right, and people that work in here are ARRTR, and often you will have ARRTR, which is radiography, plus CT as well. Now, remember, we had that PET CT scanner as well that we talked about earlier. Well, the nuclear medicine technologist takes the same test and then becomes credentialed in CT as well, because they need to have that license in order to operate the CT scanner. Okay, we take a look at all body systems. We can do axial, so that's head to toe. In certain body parts, we can do coronal and sagittal. Okay, so we can do sagittal, which is left to right, and coronal is from front to back. Okay, so it just depends on what body part we can do. We also can do reconstruction. So we take pictures in head to foot and we put them through a reconstruction or a computer program, and we can recalculate those images that we took and display them in a different body part. So if it's axial, we have a group of axial images. We can say, okay, I want to see that in a coronal image. And now you can move through the brain in a different body plane, as well as sagittal. You can do that as well. So it's a lot of things. And we can do 3D reconstructions, lots of different things that we can do in CT. I started doing CT in 1997. So I've been a CT tech for a long time. All right, you'll find these in hospitals, ERs. A lot of hospitals, especially the new ones, will put a CT scanner in the ER because it is a very good diagnostic tool. It's fast and gets a lot of information. For example, this, we see everything from the skin, there's the skin, from the skin in, right? So you get everything on there. So it is a very widely used tool and a very important part of the diagnostic imaging profession. All right, you'll also get them in imaging departments and outpatient clinics. So you get them in a variety of settings. There are some portable machines that we can use, but those are not as plentiful as the ones in the CT scanner. Right, so this usually takes up 2 to 3 rooms. We have the scan room, we have an equipment room where all the computers are that helps us produce the images, and we have a control room. So there's it's quite a large machine. MRI. So I'm an MRI tech as well. I started that in 97 with the CT. I went to a CT/MRI program and got credentialed in both. You can, again, like I said before, you can have 2 pathways to get there. So the person might be an ARRT-R and then do MR as well, or they can be the imaging professional from the other organization. Okay, so it is a very strong magnet and uses radio waves to produce an image. So I get to teach MRI physics, and we can talk overall in our program, we talk for 36 hours of of MRI physics, so that the person that is operating the scanner knows what they are doing. Here is a typical MRI unit, right? And the table that the person lays on. Then we have different devices here. Depending on what body part we're doing, we'll put a different, what's called a coil underneath or on top of you. And that will help magnify or focus, depending on what you want to look at, the images to that one body part. So you might see a brain MR with a cage that comes over the whole head, and it gets really good pictures, like right here. This is an MRI of the brain. So in the brain, you have normal fluid-filled areas called ventricles. And we can take a look at the ventricles. We can look at the gray and white matter. We can see that there's abnormal vasculature here on this particular patient. So if you see over here, there's not those black areas. The black area is blood-filled blood vessels, right? So, and that's not supposed to be here. This is asymmetrical. All right. So the person that works in here needs to know cross-sectional pathology, cross-sectional anatomy in all 3 planes, and the specific exams that are done for specific pathologies. Again, we tailor the imaging to what we are looking for. For example, there's at least 4 different ways to look at the brain. Are we looking at the pituitary or the master gland in the middle? Are we taking a look for cancer? Are we taking a look for stroke? What exactly are we looking for? And depending on that, we will tailor the images that we obtain to increase the diagnostic yield or the value of the information that we gather. And then we turn those in to the radiologist and they interpret it. All right, so here is a knee MRI. You can see the femur here and the tibia. These are muscles. This is some fluid collection. You can see, you can always hear of a sports athlete saying, oh, they tore their ACL. Well, how do you find that? You do an MRI and look at the ACL and see if it's abnormal or not. All right. So what we do is we put the patient in, we'll put you in what's called the bore of the magnet, the tube, and the atoms in your body align. Normally we have scattered atoms, they're spinning, and that's natural. So you have the alignment that is maybe going up, maybe going down, side to side, and all those different angles cancel each other out. So we are not magnetic. When we put you into the bore of the magnet, those atoms align so that they're either going with the magnet or against the magnet. Then we put radio waves in, and those give energy to those spinning electrons. And then the body always wants to go to an equilibrium state. It has more energy, so it gives that energy back. When it gives that energy back, it sends out a signal, and we calculate where that individual signal came from, so we can put it onto a image so we can see what we're looking at. So it's pretty interesting, in my opinion, and it's pretty cool. So MRI won a Nobel Prize for 2 people in the 50s for figuring out how to do this. You say 50s, wow, they've been around, but we didn't know how to separate the signal into multiple areas until 1979, 1980. That was the first time where we said, okay, well, let's put something in the system, and we can now, it's called gradients, we can now separate each body part from each other, and each atom or signal area, a voxel that we put into a pixel, pixel element. Anyway, so it's lots of stuff, and it's a very good imaging modality for a lot of body parts. So you can do cross-sectional anatomy in CT, and you can do cross-sectional anatomy in MRI. It just depends on what body part and what pathology we're looking for and the timing of that. So one is better on a certain time of the pathology or disease, whereas the other one is better at a different timing. So it just depends on what we're looking for and why. All right, you'll see them in hospitals, clinics, outpatient clinics, and in areas that don't have an MR, you can find them in mobile units. So they're in a semi-trailer, and so you raise up on a lift or go through the stairs depending on your mobility, how well you can, if you can walk or not. And then you take the image and then go home. Mammography. So mammography, you need to be an X-ray tech first. So these are the ARRT R for radiography, and then M for mammo. So we talked about sort of the energy levels for X-ray. We have a certain energy level that X-ray uses to get a diagnostic picture. The X-rays pass through in a certain way, and we obtain an image. Radiation therapy will be an image, an energy level that is higher than X-ray, because the goal is not to image, but to kill the cancer cells. So it has a higher energy level. Now mammo, because the contrast or the difference in appearance between the fibrous tissues, which are the wider areas, and the fat tissues, they're very close together in value. We call that the Z number. So their chemical makeup is very similar, and the way they pass through, X-rays pass through them, we use a lower X-ray than X-ray energy than the normal X-ray. All right, so this is one of the most heavily regulated imaging modalities. You have to have quality checks more often than everything else, and because a artifact, something that's not supposed to be on the image, can simulate a pathology. So they are very strict on making sure that everything is absolutely perfect to get the best picture, and a lot of dedicated professionals to make sure that that is going well. So you can do diagnostic imaging. For this one is a mammo screening to make sure that the person doesn't have any cancer in the breast. And then you can also do interventional. So you can do a biopsy. So for this example, the radiologist circled this area as abnormal. And what they would want to do is have the person come back and take a sample of that area to make sure that it's not cancer. Sometimes an abnormal area might mimic cancer, but is not life-threatening. So you want to make sure that you check that out, right? So it's important for our ladies in our communities to go get your mammogram at the appropriate times. Unfortunately, I lost my mother-in-law to breast cancer. She had it 3 times. And on her last go around, she lost her battle. So I want to make sure that everybody out there gets your mammograms on time to make sure that you don't have something growing in there that we could remove and save your life. All right, so this one's near and dear to my heart. All right, you'll find these professionals in hospitals, in outpatient clinics, and mobile units. So some areas of the country don't have a mammography program because they don't do enough. So you'll have a mammo semi-trailer, and they will go around to the region, and you can schedule that exam when that unit is in that area, so that people living in those areas have the screening that is so necessary. Bone density is another subspecialty. You have this special unit that the person lays on, and x-rays pass through, and then we can calculate how much x-rays went through at a certain level, and depending on how much calcium there is in the bone, the more calcium in the bone, the less x-rays pass through it. The calcium stops that x-ray, so the whiter it will be on the image. And you can calculate exactly how much went through and didn't go through, because you're using a standardized amount of x-rays to go through. So if you have more x-rays go through than the normal, you can say that the bone density is less, so you might have osteoporosis. Okay, so it's a pretty cool exam. So non-invasive, you just lay down, the person, the operator, takes the image, then it is calculated to see what type of calcium is still in the bone. Okay, hospitals and outpatient clinics are where you will find these exams done. So the registered radiology assistant versus the registered radiologist assistant. So a radiology assistant is usually a transporter. They will help you get to the imaging department. If you're inpatient or ER, for example, they'll go and bring you to the room. Now, a registered radiologist assistant is like a PA, but their sole focus is interventional procedures in the radiology department. They do diagnostic procedures as well. For example, they can do an exam that looks at the intestinal tract. So like an upper GI or a colon, they can do those under the fluoroscopy. So here is another fluoro unit, right? Interesting thing about the fluoro unit, it was discovered, or actually it was invented by Thomas Edison. So it was, the x-rays were discovered. So they weren't invented, they were just discovered in 1895 in the first week of November, and by a German called Wilhelm Conrad Röntgen. So he won the first Nobel Prize for physics for his discovery, and it was awarded in 1905. So we've been around quite a while now. So the radiologist is the physician that will interpret the images, or in interventional radiology, they're the one doing it. Now, there is a radiologist shortage in America. So we have the radiologist assistant that can go in and be what's a physician extender. They are going to do the exam and interpret it, and they are verified by the radiologist to make sure that they caught everything, et cetera. So they can do lumbar punctures, they can do myelograms, which is the injection of contrast into the spinal canal. So a lumbar puncture just introduces a needle into that spinal canal, right? So then we can take samples, as they are doing here, of the cerebral spinal fluid, or CSF, and then you can take those samples to the lab, and then the lab does their work to see if there's any type of infection in that fluid or any other abnormalities. Now, if you put contrast in through that same needle, now you take pictures of the spinal canal, and you can look at the spinal cord to see if there is a disc that is pushing against it, intervertebral disc. So between your bones and your back, you have a shock absorber, intervertebral, so between two vertebrae. The disc there helps cushion when you walk and when you move. So if that cushion gives out, it can go backwards posteriorly and hit that nerve. You know, the spinal cord is the largest nerve. So if it pinches that, you'll have pain and maybe loss of function. You can't use your arm as well as you could because you have a pinched nerve in your neck, or maybe your lower back, which is the most common. If you fail to use proper body mechanics, you might get a pinched nerve, and that pinching of that nerve both produces pain and it produces loss of function. For example, the lumbar spine, if you have a pinched nerve there, your foot, when you're walking, when you pick up your foot, you normally just bring it up. If you have a pinched nerve, your foot can drop and drag. So that's called foot drop. So you can have symptoms way down at your toes, but the area of issue could be in your lumbar spine. So that's an often asked question when I'm doing an MRI. Why am I doing an MRI of their L spine, their lower back, when their pain is in their ankle? Well, it's because the pain is most likely being generated by that pinched nerve way up top, but it's called referred pain. It goes way down to the bottom, and it is different, right? So you wouldn't expect that, but that is actually why we're looking at the lumbar spine most of the time. All right, so they can do fluoro exams, they can do central line placements. For medication, for people who have a lot of medication to take routinely, instead of trying to find a vein each time, we can put a central line in. So it's centrally located within the body. So it's a central venous access. So you can poke that catheter as opposed to finding and poking in a vein all the time, and eventually that vein will give out and you can't use it anymore. So we want to avoid that. So that's how we put in a central line. That's the reason. And the radiologist assistant can do that. And you'll find these at hospitals. Echocardiography. Okay, so this is using an ultrasound machine, right? So you have the ultrasound machine with a transducer, but you have special transducers and you have special software on the ultrasound machine in order to focus on and calculate all the body parts, all the anatomical sections of the heart. So you can see that they can take all sorts of different images using this transducer. They find a what's called the window and put the transducer there. It passes through, for example, your ribs would block the sound waves. So you can't go through a rib, so you have to go in between the ribs at a certain area. And the ultrasonographer that is focused on echocardiography will know exactly where to put that, what angle to put it, and then find the anatomical structures, take still images like you see here, or take cine images. So that's a movie using the sound waves. Okay, so you'll find these in hospitals and outpatient clinics. And again, it's the ARDMS, so it's an ultrasonographer. It might be someone that has an X-ray background or not, but it doesn't really matter as long as they know what they're doing here. They don't have to be an X-ray tech. Most people will not be an X-ray tech first, and that's perfectly fine. Then you can do a mix and match, right? So you can do X-ray, you can do X-ray MR, X-ray CT. The common ones are X-ray CT MR. That's me, I do that. There's PET CT, so a nuclear medicine technologist that learned CT, that's common. One of the least common is X-ray tech and ultrasound, but they're still out there. So anything goes, you can mix and match. So for me, I started in X-ray school, then I learned CT and MR. I learned cardiac Cath Lab, interventional radiology, PACS administration. So we mentioned PACS at the very beginning. That's the people behind the scenes managing all the digitized image or digitally collected images to make sure that anybody that wants to see them can. So that's the PACS administrator. Another area is administration. That's behind the scenes. Usually only see them if you have a complaint, because their main job is focusing on staffing, on equipment purchases, making sure everything is quality management, to make sure that all the techs are doing the right things, so that they're behind the scenes working through all that. And as a patient, you most often will not see them because they're behind the scenes doing what they do there. I was a administrator over 2 hospitals and 2 clinics. And so I did see patients every once in a while. I did some of my exams that I know how to do just so I can keep up on my licenses and interact with the patients, because I do enjoy that. Now, education. So I'm also an educator. So somebody has to be credentialed and educate all these other professionals. So I have been doing that for the last 22 years now. And I find that enjoyable. You can become an X-ray tech and do other things, right? So I went back to school and went to cardiac electrophysiology. So now I am the program director. I'm making sure that the people learning that know the ins and outs of that profession. And I like them all. There's not one that I dislike and say, oh, I don't like that. One of my favorite jobs was I would come in and do MRI and finish out those patients that were waiting. Then I'd help out in CT. When they were caught up, I'd go to X-ray in ER and do that. And I was also the supervisor, making sure everyone else got their lunches. And I also was the PACS administrator, making sure that everyone that needed to see your image was able to see it. Of course, everybody gets a log on and a password, and nobody can share. And one of the PACS administrator's job is to make sure that your confidentiality is being maintained by doing audits and say, well, who looked at this person's x-rays or MRs and did they have a right to? And if we find something wrong, we make sure that that is corrected. So that's part of that role, but a lot of it is education of the people that use it and making sure everything is up and running 100% of the time. Of course, we do go down every once in a while to make for maintenance, but you know, that's another thing. Now, people will mix and match these professions in different ways. My wife is an X-ray tech. We met in X-ray tech school. I went through the CT/MR and the other modalities, and she went to ultrasound and echocardiography. So, so that we don't overlap and we're not competing for jobs, right? So she does ultrasound full time. She's still an X-ray tech, but she hasn't done it in a while because her main focus is ultrasound. For me, I haven't done some of my modalities in a little bit, but I can always pick them up because I'm still credentialed, and you know, the people that are doing it would make sure I'm up to date and jump right back in. So it's a vast and varied career set for the people that are going to be imaging you, and they're a great group of people. All right, so limited technician. So we did talk about the technologist. Usually the X-ray tech takes 2 years of education plus a pre-req year. So all your prerequisites, your anatomy and physiology and all those other things are another year. So it's 3 years. Most are an associate degree. Then you can do all those other modalities that we talked about on top of those 2 years. So for example, I did X-ray, so that's 3 years. Then I did CT/MR, that's another year. I did cardiac electrophysiology, that's another year. So you can also get bachelor's and master's in radiology to do either administration or education. So I did those two. So the people in this field have a lot of education. So myself and my wife have many more years of education than some other professions. So it's a really good group of people that are in this medical field. Limited technician is a limited scope. They take a few months or less to obtain the knowledge to take an image of a single body part. So it might be, you can take images of the spine. So your cervical spine, your thoracic spine, and your lumbar spine, right? You can take upper extremity, so all the body parts of the upper extremity, all the body parts of the lower extremity. You can take abdomen. You can't do fluoro, so you can't move into those professions. You can't go through CT or MR or any of those other ones that you're required to be a full technologist with. And there's no skull work. They can't take images of the skull. So these people with the technician are good professionals and they know their body part very well. So I know an orthopedist that specializes in hand abnormalities. So they fix anything in the hand. So they have a hand specialist or limited technician in their office to do that exam. So that's a perfect fit for that. I had a limited tech as one of my employees, and she was able to do the spine. She had a license for the spine, but didn't take it, the board for abdomen. So she could take a spine. So for example, the L spine is in the middle of the abdomen, right? So you could take a picture of the spine, but couldn't open up to take a picture of the abdomen. Again, I'm not putting anyone down. This is a good profession, but it does have some limitations compared to the other professions we talked about. So everybody in this is, I really enjoy working with my medical imaging people, and it's good time. All right, so here are all the credentials that we talked about. There, as you can see, a lot of different things and different pathways. So for example, here, ARRT has breast sonography, so that's ARRT BS, or you can be a diagnostic medical sonographer over here, and one of their subspecialties is breast. So you can do multiple things any way that they want. So you can see that some are listed as primary. So you can be a X-ray tech radiographer, right? And that's primary. That means you do your prereqs and go into that school, or you can be an MR or nuclear med or sonography, therapy. Any of those is something that you can go straight into that field. For example, ultrasound is a primary, right? So you don't have to be an X-ray tech first. You can go straight into ultrasound. You can go straight into cardiac EP. You can go straight into nuclear medicine. So that's the field. And I hope that you enjoyed the information session. If you do have any questions, please leave a comment down below on my YouTube channel, and I'll answer the best I can. All right. So one last thing is, in America, the people in these fields are not allowed to diagnose. So we can take images in order to do our job. We know the anatomy we're looking at. We know what we're looking at. The majority of the time, there's some few that are so rare that the radiologist will call that out. But we need to know what we're looking at to see if we have enough imaging study done for the radiologist to take an image or to make a recommendation and make a report on that. So we can never say, well, you have a tumor. That's not our job. That is the job of the radiologist, to relay that information to your primary physician, and they're the ones that will do that. So that's why we always say that we can't tell you what we see when we, if you ask us, what do you see? My response is, I have enough information for the doctor to read that. And I say that whether it is normal or abnormal. It's not my place. I'm not a physician. I am an expert in imaging, and so we're. You can say that we are all fancy photographers, right? We just use different machines, and some of them are, like the MRI, are multi-million-dollar pieces of equipment. So if you are interested in any of these fields, I have another video for how to get into these fields. I've fortunately get to teach in quite a few of those. I teach in 8 imaging modalities because of my clinical experience. And I had a lot of fun with my clinical experience, interacting with people, calming people down, especially if you're claustrophobic in MR. We want to get the best pictures possible. So I help people work through their claustrophobia to get the pictures so that we can get an image, so we can make a treatment plan to see what's wrong. All right, well, I've had fun talking about my profession that I've been in for more than a quarter of a century now. And I hope you enjoyed it as well. Remember, let me know if you have any questions. Have a great day.